welcome to yet another interesting series. This is our Triple S series, which is going to focus on the EFOG Part 2 examinations. And today we are going to discuss on the station of basic skills on obstetrics and gynecology. And I am Dr. Priyadharshini, Course Director, StudyEFOG with StudyMedic. So a little progress every day is going to definitely add up to big results, and we have seen you guys preparing hard for these exams. So here is something from us as a bonus, as an add-on preparation, which is definitely going to help you for your exams. So coming to the station of basic skills, first important thing is you need to understand whether you're going to be tested on your skills or whether it is a teaching station. Why? Because the same topic can come in both the stations. So clearly read the candidate instructions to understand what is the station you are standing in. Second thing, whenever a skill is being asked to perform, make sure you're doing it in a chronological order. Do not mess up the steps because that is not the way we do with the patients. So keep that in mind and do it slowly. You have to demonstrate the a practical skill that is being asked for. Just talking the theory part of it is not going to solve the purpose, and what is expected in the station is performance of the skill. The safety, the privacy of the patient, and the consent if required is given a lot of importance. We need to consider that this is a real life scenario that we are dealing with and take it forward so you will not miss on the important points. The procedure that we do needs to be performed as per the standard practice. There can be some changes as per the local guidelines or the practice that you're doing, but remember for the examination, we have to stick on to the routine international standard practice guidelines. In the station, you will definitely have a table with some properties that are kept there. It can be a glove, it can be spatula, it can be a speculum. Whatever is kept on the table is for use. So just make sure you're wearing a glove before doing the procedure and use the properties that are appropriately required for the particular skill demonstration. And if you can do it with a real time verbal commentary, then that is the best because that helps the examiner understand that you are doing the procedure step by step. So let us see what are some sample stations you can get for this. So we have both in obstetrics and gynecology. So any of this can come as a sample station. Forceps vacuum, very very common. Performing and suturing an episiotomy, repairing a perineal tear, asking for a manual removal of placenta, performing the obstetric ribs, mechanism of labor, maternal pelvis, fetal skull, CTG, and partogram. Maternal pelvis and fetal skull, you need to understand the basics when you're applying it for your operative vaginal delivery. Coming to gynecology, some common stations we can expect are pap smear, performing a pap smear, explaining a POPQ grid, or it can be to the patient, it can be to your junior, or it can be writing down a POPQ grid. Marina insertion, pessary insertion, performing a gynecological examination, laparoscopy, entry techniques or electrocautery associated with laparoscopy, performing stations like laparoscopic sterilization, hysteroscopy, basics of colposcopy is also essential to know, and performing scans like transvaginal ultrasound and transabdominal ultrasound. These are few sample stations that you might prepare before your exams. Now, today we are going to discuss a station, and here we have the candidate instruction. This says that you are the registrar on call and your midwife has called you to deliver Sarah, who's a primigravida, by a vacuum extractor. Along with this, you have some additional information. Sarah is a 23-year-old low risk primie who had an uncomplicated pregnancy so far. She is in her active second stage of labor, but there is a delay noted and some degree of maternal exhaustion, and hence you're being called in. You have 11 minutes for this task. So, before we start off with the station per se, let me explain. as you stand outside the cubicle, you have 1 minute of reading time, and when you enter the cubicle, you have 11 minutes of performance time. So 11 minutes is quite a good number. So you have ample amount of time to do the skill. So please do it slowly. Do not be in a hurry to finish it up quickly. Use the time adequately that is provided to you. Now, in the station, we need to remember there is no role player as such. So it is just you and the examiner and a mannequin. The mannequin will be placed in such a way that is going to help you to perform the skill. Say, for example, if it is for an obstetric skill, you will have a mannequin with a fetus inside wherein you have to demonstrate the skill. You can either have a maternal pelvis and a fetal skull that is being present there. You can have the model of a uterus with a marina or a pessary being presented there. So, depending on the station that is presented to you, you will have the appropriate properties. So, there is no role player. So, here you will consider the mannequin as the role player and you are going to perform the tasks. So, these are some important points you need to keep in mind. So I will present myself as the candidate today for the exam and I'm going to perform the station for you. Hi Sarah, I'm the doctor here in the labor ward. I see that you're in labor and you've been really doing great. Congrats, well done on all your efforts and well done team for supporting Sarah all this while through. However, Sarah, I'm here to explain that, though you've progressed quite well, you might need some more help to deliver the baby out, and I'm here to offer you the support. Do not worry, we are all here to ensure you that you're going to have a smooth delivery. Sarah, from what I understand, is that you have been actively pushing and now it's getting a bit difficult for you. And so it is for the baby, and we're not able to deliver the baby well. So, what I'm going to do now is to quickly assess you from down below and see how I can help you out. Is that okay, Sarah? So, as Sarah has agreed with the examination, I move towards the foot end of Sarah. I'm standing in the foot end of the patient. I'm ensuring that I have adequate light. I'm making sure that I'm wearing sterile gloves and I'm going to do upper vaginal examination. Do I have the examination findings? The examiner says the examination findings are the vertex is at +1 station. We can see caput 1 plus and molding 1 plus. So, based on the examination findings, I am going to go ahead and I decide on for a vacuum delivery. Sarah, I have examined you from down below. The baby is doing great. The baby's heartbeat is fine. And what I'm going to do is apply a small cup on the baby's head, which is called as kiwi cup, and I'm going to deliver the baby out. Is that okay, Sarah? Do you have any questions for me? Sarah, do not panic. It is just a method of delivering the baby out, and I will ensure that you and the baby are fine. However, Sarah, I would like to know, would you need some painkillers right now? Is it okay for you? You might also need a small cut down below, which I will stitch back after the baby is down. This is just to ensure that I have adequate space to deliver the baby out, Sarah. I will be giving you some injection down below to make the area numb before I cut. Is that okay, Sarah? And also, you will just follow the instructions that we are going to tell you so that we work together as a team to deliver the baby out. Dear midwife, I also need some help. I want you to assemble all the instruments here for me. Please inform the consultant also that we are going to go ahead with the operative vaginal delivery, and in case we have any difficulty, we might need his help here also. Also inform the operation theatre that we might need an emergency cesarean just in case the vacuum is going to fail. Thank you for this. I understand that the maternal vitals are all fine and the fetal heartbeat is also doing good. I just want to ensure that the bladder is empty, and I would also like to know whether my vacuum cup is ready for me to be inserted. So the main precautions that I take here are, first is I make sure that there is asepsis maintained everywhere. The patient is towards the end of the table and her bladder is empty, and all the prerequisites for performing a vacuum delivery is kept in mind. Adequate instructions have been given to the operation theatre and also to inform the consultant. The neonatal team is already here ready to have a resuscitation of the baby if required after delivery. The arrangements have also been made for taking paired cord blood samples, and also adequate analgesics have been given to the patients, and we are ready to perform the procedure now. I stand in the foot end of the patient and I'm seeing the baby's head. So, first thing that I would like to do is to take the vacuum cup, and this is the baby head here. So, ideally, what I try to do is I try to understand where am I going to fix the cup. So I'm doing a pervaginal examination and I have felt for the posterior fontanelle. I'm going to put the cup 3 centimeter in front of the posterior fontanelle, which is the flexion point. This is the exact point where I'm going to place the vacuum cup. The vacuum cup that I'm going to use today is the kiwi cup. Sarah, please do let me apply this cup for you. Once I apply the cup, we together are going to act as a team. And when you're getting good contractions, I'm gently going to pull the baby down and I want you to push slowly. Is that okay, Sarah? I've also explained the patient that what am I going to do with her right now. So I've checked on my instruments and I've checked on the patient's safety and I'm assembled everything ready. So this is the kiwi vacuum. In the kiwi vacuum, we have, it is made up of plastic and we have an indicator for the pressure, which is the pressure gauge. And slowly, once I apply the cup, I'm going to increase the pressure. First thing what I'm going to do is wear gloves, so it is all sterile. I'm going to put in my finger and ensure that the cervix is completely dilated. I understand that the head is at +1 station with a bit of molding and caput also present there. So this situation is ideal to perform an operative vaginal delivery. There is no head palpable peritoneal also, and the bladder is completely empty and adequate analgesics have been given. I am taking the vacuum cup and I am applying it in the flexion point as described. I'm ensuring that there are no tissues that is present between the cup and the fetal head. There is no soft tissues. So once I have felt that, I am going to increase the pressure until the pressure reaches adequate. I'm going to apply the pressure. Now I understand that the pressure has been completely applied here and the applicator has moved to the green point. Moving on to the red point in the vacuum can indicate the pressure is too high and it can cause some bruises over the fetal head. So I'm avoiding that. So yes, now adequate vacuum has been applied. The baby is in correct position. And Sarah, are you getting any pains now? So once, Sarah, yes, very good. I understand you're having pain now. I'm gently going to pull down the cup. So I'm holding the vacuum and I'm giving a slow downward axial traction to bring the baby out. There is no pop-up. I'm gently pulling, 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 pulling. Yes, Sarah, please do push with the contractions. Yes, I slowly understand. Yes, I see the baby has delivered now. Immediately after the baby is delivered, I'm switching off the vacuum to remove all the vacuum effect and removing the cup out of the baby's head. I'm gently giving support to the baby. I'm holding the baby and making sure it is being delivered out. I see the shoulders are delivered and rest of the baby is delivered by lateral flexion. I'm handing over the baby to the pediatrician to take care. Sarah, congratulations on delivering your baby girl. I'm happy for you. Sarah, let me just have a check down below. I see that there's a small tear, Sarah. I did not give you an episiotomy because there was adequate space. However, there's a small tear down below which I might need to suture you. Is that okay with you, Sarah? And I am going to manage the active management of third stage of labor. Dear midwife, please give 10 units of syntocinon. I'm gently waiting to deliver by controlled contraction to deliver the placenta out. I see there is no vaginal bruises except for the small perineal tear. It's a second degree perineal tear which I'm going to suture. Thank you so much for your help. Okay, so This completes the station of basic skill performing a vacuum. Okay, so what are the sample props that you're going to have on the table? For example, in this station, you are going to have a mannequin. A mannequin is going to be basically the uterus with the baby, or you can just have the pelvis with the baby present as shown in the picture here. Also, you're going to have your vacuum present by the side. You can have some gloves, some gel, for example, present on the side. Understand that there is no patient here, so you need to talk to the mannequin as the patient, and also understand there is no midwife also here. But if you have to perform an operative vaginal delivery and you're being called in by the midwife, you need to have the situational awareness of what you're doing, and that's why I was speaking in between to the midwife. Now, let me analyze on how the feedback is going to be for this particular station. Now, the feedback, or from the examiner's point of view, the examiner is going to sit and see what you are performing in this station. He is just going to be a mere observer, and also he might have some findings that might help you. So, just in case you feel you want something, please ask the examiner. If there are any available points, they will share it with you. If there are not, you need to understand that there are no points with the examiner and just go ahead performing the station. So, if I am the candidate and I read the candidate instruction, the things that I keep in mind in the 1 minute are: first thing, who am I? I am the registrar. Second thing, where am I going to? I am going to see Sarah. For what am I going to? I'm going to perform an operative vaginal delivery or vacuum. And it's the midwife who has called me. So these are my main points I keep in mind. So what I do, as soon as I enter the station, I introduce myself to Sarah. I say why I am there, and I am starting to perform the station. I'm not spending a lot of time in collecting the detailed history, because whatever is required for me is already being given there. And just in case there's anything in between I need to ask, I can just ask them then and there. The basic idea that I'm here is to perform my station on vacuum extraction. So, going on to the detailed feedback, first thing is how am I going to describe and explain the mechanism of the instrument, the parts of the instrument that is going to carry some mark. So, in the exam, you will be having the kivi cup kept there. So, take the kivi cup in your hand, take the vacuum in your hand, explain the parts. Okay. Second thing, what are the indications? You need to explain the patient. Like, you have been doing well, but however, that you're not able to push the baby out, so I'm here to help you. Or there can be a scenario where you need to expedite the second stage of labor, say a severe preeclampsia. So if there is anything mentioned in the history, you can use that. So you need to understand what are the indications. Second thing, how are you going to apply the kivi cup? You need to demonstrate this particular skill in the given pelvis and the dummy that is provided. This carries a lot of mark, and be very sure and careful when you are performing this. Next, you are going to mention what are the precautions you're going to take while applying the cup. That is, whether adequate analgesia is provided, and also make sure there are no soft tissue parts that are included between the cup and the head. So these are some important points. What are the prerequisites? Full dilatation, head is engaged, there is no CPD, where is the station, whether there are adequate contractions, the bladder is empty, and of course taking the maternal consent. So all these must be filled in before you go on with the Ventos. You're also going to tell about the risks and complications with Ventos. You can talk about the maternal complications, this lacerations, PPH, some scalp injury to the baby, etc. So these are some risks and complications which you have to tell at least one or two to the mother before starting in with the procedure. Since we do not have a role player here, we only have a mannequin, so the mannequin is definitely not going to talk back to you to ask for the risks and complications. But however, you need to talk to the mannequin as a patient and tell, I am going to apply this to deliver the baby out. However, there can be some complications, like there can be a bit of bruise over the baby's head, or there can be a bit of tear down below, which we can suture. And how many attempts are you going to try? It is not more than 3 pulls. Okay, so in exam you're going to try, attempt, and slowly pull the baby out. If it's going to come, then yes, well and good. But in case there is a pop-up or something, remember, you're not going to apply for more than 3 pulls. Okay, now what happens if you're not able to deliver the baby cup? You have to see what is the reason, whether the patient selection is proper, and why is there difficulty, where is the difficulty. You're going to reassess, going to get the help of a senior obstetrician. Okay, and but always remember, you're not going to sit and use both the instruments together. Okay, so sequential application is generally not advised. So all this must be kept in mind. So that's why I told the midwife in between, please inform the consultant obstetrician, please inform the operation theatre, because these were just some backup steps that I keep in mind while performing an operative vaginal delivery. Now, the common causes of a vacuum going in for a failure. This can be because the clinical judgment has been poor, there's been CPD, the maternal effort is bad, there's inexperience of the operator. Okay, so you can just tell that, if you have successfully delivered the baby, then you can pat your back and say yes, the baby has come out. But just in case in the exam you're not able to pull the baby out, and you feel that it is stuck somewhere, you still have a reason to say that, I'm not able to pull the baby out. Probably these can be the reasons, and I would like to reassess the situation. All right, so these are some things that you have to keep in mind. So, what are the important points to remember here? Understand that the mannequin, you have to consider it as a patient. Okay, so you have to talk to a patient similar way you want to talk to the mannequin also. Keep that in mind. So, before start of the patient, you're going to start of the procedure, you're going to explain and get a verbal consent of what you're going to do. While performing your procedure, you're going to talk and just make sure that there is a good understanding between you and the patient, like how we do in our real time life. And after the procedure, you're going to thank and congratulate. Ask for findings with your examiner in case you just need. You're not going to take a complete history, because all that is not going to be required in this station. And remember, this is for performing the task. So how good you are at your basic skills is the main area of scoring in this particular station. So my advice will be to practice the stations. Though we are doing this in and out in clinical practice, to have at least one revision before the exam is definitely going to be fruitful for all of you. So consider your real life scenario when you're performing tasks like an external Catholic version or doing an operative vaginal delivery. It is just going to be the same. Whatever properties are kept for a particular purpose. So never underestimate them. Start using them and do the procedure. So, what are some important topics you need to read, especially for this? You need to understand some basic obstetric definitions, the diameter, the presenting part, and all that. At what level can you use the instrument deliveries? What are the safe conditions that is needed for a safe application of these instruments? The indications, the contraindications. Kindly have a look at everything. The trial of vaginal delivery, operations or rotational vaginal delivery, the complications associated, have a go through of all of them, because these theory will be definitely requiring for you to perform the skills. So just have a look at all of them. So the marking scheme, of course, it's going to start by doing a communication. The communication is basically introducing yourself, checking the understanding. We know the mannequin is not going to talk, but still you need to check that in between. Your clinical knowledge of the parts of the instruments, how we are going to apply it and perform your clinical knowledge marks. Your technical skill is you performing it on the mannequin and successfully delivering it. All right, and not to forget, you are going to have a global evaluation as to how you are approaching the patient and how you are doing the procedure. So all this together is going to give up to 20 marks in this particular station. And basic skill is one of the very, very easy stations to pass through. You do not have anyone else. It is just you, the examiner, and the mannequin that's kept there. So you have all the 11 minutes with you. There is not going to be any kind of interruption. So use the 11 minutes adequately and judge it accordingly and perform your station. So, with more than 1 lakh followers for us on YouTube, I hope this kind of series will definitely add on to your exam preparation. Stay tuned for more of such triple S series videos, which is going to help for your EBCOG Part 2 examinations. Thank you.